we try to be very mindful of that. And I don't know if sharing the experiences of older people with LCC and how they felt about their cadence of treatments might be a way to address that. But I thought that quote from Azucena really resonated with me. I'm talking about dystonia. This is my bailiwick. I focus on the treatment and diagnosis of dystonia, both in the lab and in the clinic. As I said, I'm a CP specialist. I run our cerebral palsy center, and I'm lucky to be here with Lauren Gottschalk, our nurse coordinator, who actually runs our CP center. So we're both happy to talk about this. This is my funding sources, so financial disclosures. And I also have a disclaimer that a lot of what I talk about today is going to be about dystonia due to atypical brain development of all sorts of causes, because that's what we have the data for. There's actually very limited data on dystonia treatment and diagnosis for just one specific cause. And with also that said, another disclaimer is that I'm here also to learn from you, and I've already learned a lot. And then subset of that is share our work. I'm excited to get your thoughts on all of this as well. This is a combination of two formal definitions of dystonia, one of which was actually just updated last year. Dystonia is voluntary movement-triggered overflow muscle activation that's arousal dependent. What does that mean? When I talk to families about it, I say every time you try to move or your child tries to move, as the case may be, a part of their body that they didn't want to move moves out of their control. Or every time you handle your child or your child gets really stressed out, a part of their body that they didn't want to move moves out of their control. So if you think about lifting someone from their wheelchair to their bed and they get really tense and their back arches, or you think about changing the diaper of a young child and their legs cross and you're like, why is that happening? They were really chill and their legs were loose sitting in the chair. Or if when you're reaching for something and then your other arm twists up, or as you're reaching for something, the arm that you're reaching with twists up. Or when you're walking, your legs cross and you're like, my legs didn't cross when I was sitting. I don't know why they're crossing when they're walking. Those are all examples of what dystonia can look like. When I think about dystonia in the context of people who have atypical brain development, and LCC does fall under that category, so does many types of cerebral palsy or CP. We often see both high tone and low tone. And I'm sure you've all seen that in your kids or in people with LCC who've been affected, that there are parts of their body that feel really loose, seem really loose and floppy, and parts of their body that are tight. And sometimes the parts of their body that are tight may be loose. So it's hard to tease out what aspects of how someone moves can be due to low tone or high tone at any given time. And high tone itself can be divided into a few categories. Rigidity is one of those categories that in general can be rare in kids, but there's an aspect of rigidity that you heard from Dr. Frazier that Dr. Tochin had identified already in people with LCC. So bradykinesia, or slowness of movement, often tends to go along with rigidity. So this is when a clinician thinks about it on exam, if you move someone's arm, regardless, or leg, or any part of their body, regardless of how fast you're moving their arm or their leg, there's always the same sort of resistance. It's always the same degree of tight, regardless of how you're moving someone or how they're moving. It's always the same degree of tight. It's associated with slow movements. So bradykinesia, that literally translates to slow movement. And when we hear people describe it, these are actually quotes from families describing their own slow movement. So bradykinesia for someone while they're walking, a mother characterized watching a video of her son saying that it looks like he's wearing flip-flops that keep getting stuck in the mud when he's lifting his feet, that it's hard for him to lift that foot because it looked like he's wearing flip-flops stuck in the mud, or moving through molasses, moving through something that feels really thick. So if you see signs or feel signs of that, that could be an example of rigidity. The most common types of tone we see, high tone, we see in people with atypical brain development. This does include LCC or spasticity and dystonia. Spasticity is when, from a clinician standpoint, every time when you try and move someone's arm or their leg or a part of their body, if you move that part of their body really fast, you get an increase in how much that arm is resisting your pulling. So if you move it really slow, maybe there's some degree of tightness, but if you move their arm or leg really fast, you have a higher degree of tightness. You may have heard a clinician describe a catch. I don't know if that sounds familiar to anybody, that you might feel a catch when someone's stretching your arm or your leg really fast. That catch is that increase in resistance you feel when someone is stretching really fast. When you are experiencing it though, I don't know, I may be checking my kids for spasticity all the time. That's my own pathology, but most people are not checking their children for movement disorders all the time. So how does it feel? So spasticity is always going to be, if you have an arm or a leg or a part of your body that's spastic, it's always going to be there. It's always going to be present to some degree. It might get a little bit better when you're sleeping. It might get a little bit worse when you're sick, but it's always going to be in that limb. You're always going to feel it. And it's also not triggered. So it's not like that arm is going to get tighter or is going to twist up when you're trying to do something else. It's just going to be the same degree of tight regardless of what you're doing. So if you're, for example, if your legs are crossing when you're walking, if that crossing is due to spasticity, those legs are going to be crossing when you're sitting too. Dystonia, on the other hand, is different. So you can feel or look like you have low tone at baseline. For example, your legs are not crossed when you're sitting. It looks like your legs are real loosey-goosey. But then when you start walking, things get tight. Your legs start crossing, your toes start pointing. But then when you're chill, or when a child is sitting on their parent's lap, for example, they look really loose and comfortable. But all of a sudden, Dr. Boomer walks in and picks up the kid, then they get really tight. That's an example of stress or handling triggered dystonia. We see a lot of that in clinic. And the beginning of my movement disorders exam, my movement exam, is how does this child look when they're at their most chill and I have not stressed them out yet in any way? That is the baseline from which I'm working upon to try and understand whether someone has any one of these movement conditions. The other key part of dystonia is that it's really variable. Classically, it's absent during sleep. So often I'll ask my families, does your child sleep kind of frog-legged, splayed out compared to how they look right now in their wheelchair? Or are they always tight? And because my clinic visits are 30 minutes, right? And that child may have already been stressed out when they're coming into the clinic visit. So they may be tight the whole clinic visit. So I really rely on families to help me understand that variability in tone, to be able to understand whether dystonia is a key component of their presentation. It's triggered by movement, as I said, and it's activating your muscles without meaning to. We see dystonia being associated with a lot of pain. It's one of the most common causes of pain in people with CP in particular. It's often associated with limitations in movement. So people that have more movement impairment tend to have more dystonia. Treatments for it exist, and it's a different treatment pathway than other types of high tone like spasticity. So it's important to identify it, although the data is very limited, and I'll get into that. And a big problem we have with dystonia is that it's difficult to diagnose, and it's also difficult to tell apart from other movement conditions. And that's important because the treatment pathways can be different. We worked with caregivers, adults with cerebral palsy, caregivers of kids with all types of atypical brain development, clinicians and researchers, to come up with a list of priorities to help us understand how we should address dystonia in people that had any sort of cause of brain development needs or issues. And this was the top 5. I'm going to focus on our work in these middle 3. I'll start out with what we're doing on improving diagnosis and severity assessments of dystonia, which has a lot of potential for overlap in what you've heard about thinking through natural history studies and clinical trial readiness. The first thing we had to do is let clinicians know this was a problem. We're not the most humble group, I'll tell you. So I think it's difficult to tell someone who's a movement disorder specialist that we're not good in routine clinical evaluation of doing the thing that we're supposed to be good at doing. And it turns out that when we looked at WashU, which I think, I'm biased obviously, I think my hospital is an incredible hospital. It's a tertiary care center. I run our CP center. I think it's fantastic there. When we looked at children who had neonatal brain injury and we knew that they were at high probability of having motor impairment, only 30% of those kids had their tone types, meaning what kinds of movement conditions they had, identified by the time they were 5. And even when we looked at our own notes in our CP center, and I contributed to this low number before we instituted all of our quality improvement initiatives. But even if we looked at the own kids we assessed during routine clinical care, we were only identifying their leg dystonia accurately in 12%. And that's based on, we went back and looked at all the videos we took of them and we were like, oh, do they have leg dystonia truly based on this video? And then if we decided they did, we went back and looked at our own notes and saw that we weren't identifying as well as we could have. So if we're talking about ongoing clinical care at any institution, and this is, I live and breathe this stuff, right? And this was our state of affairs as of 5 years ago. There's a lot of room for improvement here. So one of the things we did was think through, how do we standardize how we look for dystonia in clinic? There's a bunch of stuff on exam that on items 2 through 4 that we now document in our notes. But what I really want to focus on here is item 1, that we ask the family about tone variability. Again, I have 30 minutes with your child 2 to 3 times a year. You are the world's expert in your child. Your child is the world's expert on themselves. So I really do rely on families to talk to me about how variable their tone is and their movement patterns outside of the clinic. We have different and complementary expertise, and incorporating that in really helped improve. We did this across 3 sites, improved the rates of dystonia diagnosis we saw in people with atypical brain development from 50% to 70% of the people we saw, which matches research-based numbers. So the kind of numbers you might be seeing in the natural history study that you're all a part of. We want to hit those numbers in clinical care. So doing something like this helped with that. We also wanted to make sure that we could generalize what is known as the gold standard, which is experts, in this case, movement disorders physician in a room talking about dystonia. How do we generalize what they say about a video of a child they might see and say, oh yeah, I think this is dystonia? That's not generalizable to everywhere. So how do we generalize that to people who may not have the luxury of being able to sit and review videos for hours on end and understand that? What we did was we had experts review videos of people with different types of brain developmental issues as they walked. And in these 2 videos, neither of these young men have LCC, but I'll tell you that they both have different types of brain development issues. The person on the left didn't have any dystonia. I wonder if I can go back and do that again. Maybe not. Okay. But if you saw, the person on the left didn't have any dystonia, the person on the right did. And they had that variable, like, ooh, I can do it again. Fantastic. Thank you. The person on the right, you see the veering. So stride to stride, that's variable. Step to step, it's not the same each step. Sometimes a leg is crossing in, sometimes a toe is crossing in. That's a sign to us that dystonia could be a part of it. That could also be a sign that there are balance issues. That could also be a sign that there's weakness. So it's sometimes hard to tease out with walking alone whether dystonia is a contributor or not, but you can for sure see that it's not only spasticity, because spasticity would look the same gait cycle to gait cycle. There are other things at play here. When we asked people to think through, if you look at these videos, what are the features of dystonia that you see? We wrote down everything they said, and we analyzed what features they said. And then we thought, okay, if they're seeing the features in video, maybe we could get a computer to see the same features. So we used Deep Lab Cut and OpenPose for people who know that software, free software, to be able to understand, to actually quantify the things that experts said, and then develop measures of these features. And if you didn't notice that outline, shout out to Dr. Tochin. Laura Tochin was one of the experts that analyzed these videos. So how did we do this? We looked at videos of people walking. We also looked at videos of people doing a seated task, because not everybody that has an issue with brain development walks. So we wanted to make sure that we had a task that people could do who didn't usually walk to get around as well. So this is a seated task called a seated hand open close task. Why we ended up, and that task ends up being our bailiwick. And so here's why. We asked a group of experts across the country and globe really to analyze dystonia severity in videos of children, this is with cerebral palsy, performing a 40-minute motor exam. Now that's a lot. It is a lot for routine clinical care. It caused a lot of fatigue for people to do that exam. And we wanted to know, is there a part of that exam that is just really good at helping us identify dystonia compared to the other parts of the exam? So then when we looked at the 40-minute exam, we said that's our baseline. That's our gold standard, what people say for the 40-minute exam. How do these other parts of the exam compare to the full exam for dystonia severity? And the best one was the seated upper extremity task, which is the seated hand open close task. It ended up, that 5-minute task ended up being almost as good as the full 40-minute exam. So what does that look like? This is Jan Brunstrom, who started our CP Center. She was also last author on one of those Vacizumab case studies that Dr. Frazier presented. This is a young lady doing that hand open close task. And you'll see that she has dystonia in her arms. So as she's lifting up an arm, you see that arm, that clawing sort of position in that hand. And you'll see that when she's doing an open close with one hand, that other arm doesn't need to be moving, but it does, right? It pulls in, it twists. That's an example of overflow movement or dystonia. This is a much more subtle example. So this is a young man who's also doing the hand open close task, and he does it with that hand. Then he does it with the other hand, and the thumb on his other hand goes up when he does the hand open close with his left hand. So that can be an example of really mild dystonia too. So even if it's not obvious, you can still see it. What time am I at? Can someone give me? Okay, keep going. Okay, cool. Great. So what we did was we analyzed how experts describe those videos to try and understand what are the features people are seeing that help us understand what dystonia is in these videos. Often when talking about dystonia severity, they talked about, so here the darker colors are more severe dystonia as rated by the experts. The lighter colors are less severe dystonia. So the more severe someone's dystonia was thought to be, the more it involved their shoulder and the less it was said to involve their hand. So more involvement closer to your body or higher up on the arm. And then there was a big discussion, particularly on the mild end, of differentiating mirror movements from dystonia. There's something that we see a lot of kids with brain developmental issues do, and some of it is typical development. It's called a mirror movement. So when you move this hand to do this hand open close task, the other hand can follow. And a version of this that one of the physical therapists in our clinic talks about is you'll see sometimes little kids when they're cutting with scissors, you'll see their mouth kind of mirror the cutting. That's mirroring too. And that's just your brain's way of saying, oh, we're just super connected right now. We don't know what connections we need to outgrow, but everything's connected and our body's just going to do stuff together. Very common in young children. And not something that we need to drug, not something that we need to medicate away, and can also be really helpful. So some of our kids will use, young adults actually typically, will use their mirror movements to their advantage. So if they want to grip something with a weaker hand, they'll squeeze their stronger hand, and that activates gripping in their weaker hand. Our OTs will sometimes leverage this as well. So we don't want to take that away, and we need to differentiate that from dystonia. Dystonia doesn't mirror. So if you're doing this and the other hand does this and it follows the same speed and same sort of shape, that's mirroring. But if you're doing this with one hand and the other hand's doing this, that's dystonia. Okay. The other thing that they also noted is that this hand open close task was everybody's favorite. Clinicians just ended up loving this thing when looking at videos, that it was just really valuable for identifying who did or did not have dystonia. This is an example of this hand open close task across 4 people in our clinic. I'm not sure. Oh, or is it all freezing? Let's try. Oops. Can we try going back? That's okay. I showed you guys some examples of the hand open close. Oh, yay. Thank you. Let's just start with one video. See how that does. So this young lady this actually shows you the full task. So important parts of this task for leg assessment included is that we leave the legs dangling so we can see how much overflow there is. And you'll see that when she does her hand task that the legs start coming in. So that's overflow. And then you'll see they come in more the more she does the task. And even though her face is blurred for her own privacy, you see that she opens her mouth as well as she's doing that task. And it's more and more as the task goes on. So that sort of overflow triggered by a movement that shouldn't necessarily trigger that is an example of dystonia. And the less that happens, the less severe experts end up grading the dystonia. This ends up being valuable for us because if we can quantify that, we can grade severity, we can do it in an automated way and do it quick and do it cheap. That's what we did. So this is free software that if you upload a video of yourself or your patient or your child doing a seated hand open close task, will tell you whether or not they have leg dystonia. And it's with 83% diagnostic accuracy compared to expert consensus. And I always tell people this is a B grade, and you never tell an Indian that they're getting a B because we'd be really sad about that. But it is 83% diagnostic accuracy compared to 12% accuracy of us without anything, right? 5 years ago, I said we were 12% accurate compared to video assessment. This is 83% accurate. So it's far better than what you would do with typical clinical care, even with someone who cares a lot, because I do care a lot, but this is the best I could do in clinic without all of our interventions. The other thing we just expanded Dystonia to do is assess leg dystonia severity and has 90% accuracy for that compared to expert consensus. So we did hit an A, although it's an A minus, but still, I'll take it. And the other thing is severity assessment during routine clinical care is really hard. The tests that Dr. Tochin has been painstakingly doing for natural history studies, the BADS and the BFM, those are very time-consuming tests to administer. So if you want to track that on a regular basis, no way. So something like this could help in between those more intensive, longer assessments. This is highlighting that this is something else we've instituted in our clinic. I've talked a lot about what clinician experts say dystonia is. If we ask families these questions, or people with high tone, these questions, when you try to move one part of your body, does another part of your body move without meaning to? Or during activities where someone handles a part of your body, do you move a different part of your body without meaning to? If people said yes to both questions, there was a pretty good shot they had dystonia. This is already better than anything I've come up with any sort of machine learning technology. And if they said no to both questions, there's a pretty good shot they didn't have dystonia. So think about these questions, ask them for yourself or ask them for your child. Does your child fit these things? The other thing we can do is we ask people to describe when they said yes to these questions, what do you see? And it turns out that people that have, so this dark blue D is dystonia is their main symptom. S plus D is they have some spasticity, some dystonia. S is they just have spasticity. So if you look at the blue column, that's people that primarily have dystonia as the symptom that's impacting them. They tend to say that the movements they notice the most are the ones affecting the middle of their body. I've talked a lot about arms and legs, but families tend to notice chest, trunk, this area. They also note, and this is something that's not in the literature, but I think families have a gut. I'm sure most of you would agree with this, just me telling you this. We talk about dystonia being arousal dependent, and that includes things like being really happy or being really excited can trigger your dystonia. And I still tell people that, but obviously we're not going to treat away your happiness or your excitement. Families say that the main thing that triggers their kids' dystonia is a negative emotion, like anxiety or fear. They're less likely to say that excitement or happiness triggers dystonia. Now, we need to validate this prospectively, but this is a big thing that families are citing as a trigger, more so than a positive emotion as a trigger. Okay. So that was diagnosis severity. This is a summary of that. So always think about dystonia, always ask about it, ask about these triggers, think about it as the families, as clinicians ask about it, think about this hand open close exam and look for this leg crossing as a sign of dystonia. Okay, rehab and psychological management approaches was another big one that came up in our assessment. There are lots of things that can trigger dystonia: pain, poor sleep, heightened mood, in particular, some of these negative emotions. I'm going to mention seizures briefly because in a lot of our kids that have epilepsy, sometimes their movements can get worse if their seizures are not well controlled. So controlling their seizures can help their movements. In our clinic, we see, again, all comers of people with motor impairments due to atypical brain development. Majority have dystonia. A good chunk of them have one of these other things too. So we ask everybody each of these things in a questionnaire basis every visit because it affects how we think about their movement. Seizure treatment, obviously we're going to think about anti-seizure medications. Dr. Tochin already gave an incredible talk on that. For the other things, this is typically what we go to. We think in terms of triggers of dystonia. So we think about gabapentin as a medication for pain-triggered dystonia, in addition to addressing the underlying cause of pain. Clonidine as a treatment for sleep-triggered or poor sleep-triggered dystonia. And then we do a lot of mental health management because these negative emotions can trigger dystonia. And that includes SSRIs, so medications that may otherwise be used for anxiety or mood control. And I will put people on a medication for anxiety. Yes, it treats their anxiety, but I'm doing it for their dystonia. I do it all the time. And it's one of the most effective ways to treat dystonia that we've seen in our kids. So if you see that component, instead of thinking of tone med exclusively, an anxiety med or a mood med might also be useful. Okay, this is a scale, a caregiver reported scale called the Dyskinetic Cerebral Palsy Functional Impact Scale that thinks through not just what is the severity of your dystonia and adding it up across your body parts, but thinking through how does it affect different tasks. We try to think about dystonia in this way, not just overall I'm gauging what the severity is, but also how is it affecting your daily life. So when we think about rehab and psychological management approaches, we always think about triggers, treating those triggers and making sure we're goal focused. Last part of this is current treatments. What is the effectiveness of current treatments and what do we know? There was a meta-analysis of current treatments for dystonia due to atypical brain development that came out a few years ago. The best data we have is for a lot of surgical treatments. Intrathecal baclofen and deep brain stimulation have the best data in kids at this time. The other one that has good data is botulinum injectables. So particularly for people with dystonia where the limitation is affecting one body part, botulinum toxin or phenol, which is another injectable, can be really helpful to treat. And then I can get into surgical treatments for people who are interested. There are a lot of considerations there, particularly for people who have low tone to keep in mind. But injectables do have a lot of data to support using them for treatment of dystonia. We don't have a lot of good data for meds. Honestly, we try a lot of stuff, but the data is lacking. The only meds that we have any data for are these three: trioxyphenidol, clonidine, and levodopa. And in people with brain injury mediated dystonia, the only medication that has data to show that it may improve dystonia is clonidine, not trioxyphenidol and not levodopa. When we ask people who treat dystonia in kids with cerebral palsy in the US and Canada what they used, there are a lot of things on that list, but none of them is clonidine. If that is a medication that you haven't, if you or your child are experiencing dystonia, it's a medication you haven't tried. It may also be a medication that your physician may not have thought of and something to think through as well. Something else you don't see on this list is clobazam. I asked Dr. Tochin about that a little bit earlier. Clobazam is a lot like clonazepam and diazepam, but it has fewer side effects. So it's something that, especially if your child or you are experiencing seizures, thinking about clobazam as a tone med could also be helpful. This is the overall dosing and indication regimen for these meds that has been used for dystonia. I put this up here for reference, so you'll have it. I'm happy to send these slides. And then this is the pathway that's been recommended based on this dystonia treatment data that we have. And what I'll do is I'll cut to the chase. The initial treatment that's been suggested is baclofen because that manages dystonia and spasticity, which a lot of people that have brain injury mediated dystonia have, including people with LTC. But the downside is that baclofen makes you floppy all over. So if you have low tone in your trunk, it's going to make that worse. So it's a big negative if low tone is something that is affecting how you function. And then there are a bunch of things that they say don't necessarily try it first line, including trioxyphenidol, levodopa, and cannabis, which we can talk about in a little bit. The two things that they did recommend second line, that we did recommend second line, is clonidine and gabapentin. The clonidine dosing wasn't on the last slide because not a lot of experts in the US, Canada are currently using it to treat dystonia, but this is the typical dosing that we would use. Okay, so that's what we have on current treatments. That data is lacking for oral medications. Clonidine may be underutilized, and that if injectables haven't been brought up for localized dystonia that's preventing you from achieving a certain goal, to consider it. We talked about diagnosis and severity, thinking about this hand open close task, thinking about variability of tone in day-to-day life and discussing that with your clinician. Rehab psychological management approaches, including thinking about triggers and addressing that first, and how far we have to go for effectiveness of current treatments. We actually have a trial revision for comparing treatments for dystonia that Danny is set to be an advisor on, fingers crossed. So we'll let you know how that goes. Maybe we'll actually get some data for what medications we should be using. And with that, I'd like to thank everybody involved in this work, including Dr. Tochin, right here. Thank you. Okay.
I'm wondering if you have any sense from your own practice or from anything else about why clonidine is underutilized. And I don't necessarily think about it first line, but there also seems to be like different varieties of dystonia or different sort of brands of dystonia, and especially in people who have brain injuries. And maybe I personally am more likely to go to gabapentin or clonidine for certain types of CP presentations, or more of kids who maybe have more of the, for lack of a better term, agitation piece of things. And maybe I'm less likely to move to that for some of the videos that you showed that have the lower dystonia score overall. Do you feel like you have a sense of, for different varieties or brands of dystonia, that certain medications would be better, or does that account for part of the difference, or I don't know?
Yeah, great questions. I'll tell you my practice in a largely data-free zone, so expert opinion, so to speak. If I see that someone does not has a normal brain MRI, I feel, and they have dystonia, I think a lot of the circuits that would be affected by trihexyphenidyl or carbidopa levodopa are still tend to be intact. So I think those medications tend to be more effective for that population. If I see that there's someone that has injury in their, or some sort of lesion in their brainstem, that which is where dopamine might originally come from to go to the striatum and help with movements, and they have dystonia, I'll also lean more towards carbidopa levodopa. Otherwise, for people that have some sort of lesion or injury in their deep gray matter and their basal ganglia, or even cortical injury can cause dystonia too, I don't tend to go for those medications first, because usually the end target has already been injured in some way. So that's when I'll think about, after baclofen, to some degree, again, limited by how low tone someone is, that's when I'll go to gabapentin or clonidine as the next line meds, or think about mood related trigger management. I don't usually do, if I can, I'll do gabapentin first before clonidine, because clonidine makes people sleepy. So that's why I like using it in people that don't sleep well. And there are also many forms of clonidine that can mitigate that. But gabapentin tends to be pretty well tolerated by a lot of our families, a lot of our kids. So I will try that after baclofen, or if baclofen isn't an option. Even for people with mild dystonia, and we've seen some benefit even for mild, because what I think is mild could really be functionally, I'm preaching to the choir here, but could really be significantly functionally impactful for the person. The last thing I'll say is, if it's dystonia affecting one specific part of your body, and that's the part of your body that's limiting you, I would not, those kids do best with Botox or injectables. So I would do that instead.